Okay, hey guys, so we're going to do chapter 14, BLS, resuscitation, CPR, and shock. Um, we'll probably move through this pretty quick because I'm also going to teach this in person, hands-on, on one of our skills days. So, um, let's see. So, introduction, the principle basic life support BLS were introduced in 1960. Specific techniques have been reviewed and revised regularly. The most recent review was 2020. It was conducted by the International Alliance Committee on Resuscitation. So, elements of BLS, non-invasive emergency life-saving care used to treat medical conditions, including airway obstruction, respiratory arrest, and cardiac arrest. Focuses on the ABCs, which by now we've discussed ABCs, so our airway, breathing, circulation. So airway, is it open or do we need to open it? Do we need to use a type of adjunct? Breathing, are they breathing? Are they working to breathe? Because that's not good. Do we need to breathe for them? Do we need to give them a little extra oxygen? What's their respiratory rate and quality? And then circulation. So what's our pulse? What's our pulse rate? What's our pulse quality? What's our skin condition? So what's our temperature? Like when we touch them, are they hot? Are they cold? Um, what color is it? Are they pale? Are they red? Are they normal? Um, and are they moist? Are they dry? Um, are they clammy? This is your ABCs. Ideally, only seconds should pass between the time you recognize a patient needs BLS and the start of treatment. Um, Permanent brain damage is possible if brain is without oxygen for 4 to 6 minutes. Um, that's super important. From the time someone collapses of cardiac arrest, they have a roughly about 7 minutes worth of oxygen from that last breath they took. Um, so we need to begin CPR immediately to cycle that oxygen that they still have to the brain and the organs. Um, I'll go back for a second. That is really important. That's going to be a test question, by the way. That 4 to 6 minutes, permanent brain damage. So remember that. Time's critical. So 0 to 1, cardiac irritability, 0 to 4, brain damage, not likely. That 4 to 6, brain damage is very possible. 6 to 10 minutes, brain damage, very likely. More than 10 minutes, it's irreversible brain damage. That is dead tissue, that is dead muscle cells, whatever. Um, the way I remember it when I teach BLS is um, it's the 10-minute killer. Um, Remember 10 seconds, which we'll get into in a minute, and 10 minutes. 10 seconds, we never check pulse or breathing for more than 10 seconds, and then 10 minutes without oxygen, the brain's dying. So you can remember that. Cardiopulmonary resuscitation um, reestablishes circulation and artificial ventilation in a patient who is not breathing and has no pulse. That is CPR. So when we do CPR, we are literally um, pumping the heart because the heart is not pumping itself. Uh, when we give ventilations, whether it be through a pocket mask or a barrier device, or whether we're using a BVM, and when we give those ventilations, we are just keeping a somewhat oxygen supply to the body while we pump the heart for them and cycle it. Yes, CPR by itself can save lives. We're going to get a little bit deeper here in a little bit about AED. That's when you up your chances drastically. So, CPR steps, restore circulation, perform chest compressions. We're pumping the blood for them. Open the airway. We'll talk about the maneuvers to do that. And then restore breathing, provide rescue breaths. The AHA on lay persons or pedestrians kind of teaches now compression only. Ben, we are EMS and we have the equipment. We do give rescue breaths. Usually we have a BVM. We can establish an airway using like our eye gels or intubation. Um, and so we are able to give them that high concentration oxygen. You must quickly identify patients in respiratory and or cardiac arrest so that BLS measures can begin immediately. The sooner we start them, the better off we are. BLS differs from advanced life support. Advanced life support includes that cardiac monitoring, intravenous fluids and medication, advanced airway adjuncts. Uh, so we put the AED pads on, we can monitor the waves. Um, we can start IVs or IOs. We're going to probably be pushing like epi and have normal saline drip going. Advanced airways, that's going to be anywhere from your King Airs, your eye gels, or your intubation. So the chain of survival, this is the American Heart Association's chain of survival. So recognition and activation of EMS, immediate high quality CPR, rapid defibrillation, basic and advanced EMS, ALS and post-arrest care. So this is when we've got them back or we've got them to the hospital and got them back. Now they're a higher level of care. And then we've got recovery. And it's going to break those down. So the AHA chain of survival, recognition, activation of the EMS system, immediate high quality CPR. So we got to get that oxygen cycling, rapid defibrillation. This is going to jumpstart that heart and try to get it to go back to regular rhythm. Basic and advanced emergency medical services. That's when EMS arrives, and hopefully we can take over from there. Um, ALS and post-arrest care. So this is higher level. We've got to the hospital where they can do even more. And then recovery, what it takes for that patient to get fully back to themselves. Um, Always begin by surveying your scene, complete primary assessment as soon as possible, evaluate ABCs, determine unresponsiveness. Should take less than 10 seconds. There's that 10 seconds again. So, just like any call, BSI is my scene safe. I want to make sure it is safe for me to go in there. Are there down power lines? Is there 5 people down on the ground for absolutely no apparent reasons? Because that's going to tell me there's something not safe in there. Um, when we do get there, hey, are you okay? We shake them, we check them. If they don't respond, we do that either head tilt, chin lift, or jaw thrust, which is coming up here in a minute. We look, listen, and feel. So we're looking for chest rise and fall. We're listening for air movement and feeling for air movement. And we're also checking that pulse all at the same time. And this should take less than 10 seconds. Basic principle of BLS are same for infants, children, and adults, although cardiac arrest in adults usually occurs between respiratory arrest and occurs before respiratory arrest. Sorry. The reverse is true about infants and children's. So most of the time, um, you're going to have a respiratory issue causing a cardiac issue in children. Oh, let's see. We talked about this. We're going to assess. So hey, what's going on? Can you hear me? We shake, try to arouse that patient. We can sternum rub. So this is your AVPU. So are they alert to you? Does it take verbal stimuli? So do you have to raise your voice or talk to them to get their attention? Painful stimuli. So we sternum rub, pinch the back of their arm, hit a pressure point. If none of that's working, they're unresponsive. So there's your AVPU. Um, Vital link in the chain of survival is that automated external defibrillator, which I said we'd talk about. Should be applied to cardiac arrest patients as soon as available. If you witness cardiac arrest, begin CPR and apply AD as soon as it is available. So that's just part of. So I survey my scene. I see the problem. I go up. Hey, are you okay? I look, listen, I feel there's no pulse, no breathing. We call 911 immediately, and we send someone to get an AED. Children, apply after the first 5 cycles of CPR, use pediatric size pads and dose uh that yeah, it usually has a teddy bear on it and it will adjust the amount of electricity delivered to the child. If neither is available, then use an AED with adult size pads. Um, and we're going to put one on the chest and one on the back, anterior and posterior placement, which we're going to do all this in class. So special situations, pacemakers, implanted defibrillators, wet patients, transdermal medication patches. So your pacemakers and implanted defibrillators, you're going to be able to see them up here. It's going to be a raised area, like a circle or a square. We just move those pads a little bit. We don't put the pads over that. We just move them away from it a little bit. Wet patients, we need to try to wipe down, whether we use a towel, their shirt, whatever's handy. We just try to wipe them down real quick. Those transdermal medication patches. And this is anywhere from your nicotine patches all the way up to, your narcotic patches or we want to use a gloved hand. Never do it bare skinned and remove that patch, wipe it. I don't know why I was using my arm. Wipe that area and then put the pads down. Don't ever put the pad over that. For CPR to be effective, patient must be supine on firm, flat surface. We cannot do effective CPR while they're in the bed or they're in a recliner. Um, we need to get them laid down on a hard surface. Must be enough space for 2 rescuers to perform CPR. Log roll patient onto the longboard. Quickly check for breathing and pulse. Visualize the chest for signs of breathing. Palpate for carotid pulse. So we have conscious patients, we go radial. If we have unconscious, we go carotid. And you should be able to find it within 10 seconds. If you're one of those people who have problems, you're not sure where to check, go ahead and practice on yourself. You can do this while you're setting up the house. You can do this driving down the road. Get used to finding that pulse. That way you can do it quickly on scene. Provide external chest compressions. So apply rhythmic pressure and relaxation to the lower half of the sternum. Uh, Compression, squeeze the heart, acting as a pump to circulate blood. Avoid leaning on the chest in between compressions. Once again, we're going to practice this in person. Um, there are techniques that you can learn that make it easier because if we're getting wore out too fast, we're not giving good compressions. So in class, we will practice body mechanics and technique to help you go longer. Administer chest compression. So allow the chest to completely recoil between compression. The proper hand position is critical. Injuries can be minimized by proper technique and hand placement. Um, let's see. The heart lies slightly to the left, middle of the chest. We know that. Sternum and spine. Okay. So I'm sure it goes into this, but we're going to go pretty much center chest or natural nipple line is our area to go for. We're going to compress 30 compressions to 2 breaths. We're going to go 2 inches deep. Um, if we have an airway established, if we have an iGel, if we have a King Air, LMA, intubation, any of that is established, then whoever is in charge of bagging can give that 1 breath every 5 to 6 seconds. Otherwise, if we're still giving a breath through just a barrier device, we're going to give 1 breath, 1 sec, or we're going to give 2 breaths. Each breath is 1 second. So it's 2 inches deep, 30 compressions, 2 breaths. We want that chest to go down 2 inches and then all the way up. We're going to go about 100 to 120 per minute. So here it talks about opening the airway. So the most common is the head tilt chin lift. Um, see if I can get this on there. That is not what I wanted. Maybe that's what I want. That's what I want. So right here, it's the head. and then the tilt chin lift. I mean, it's exactly what it says. We'll just um what this does, this is a non-traumatic, there's no chance of spinal or neck injury. It is literally pulling the tongue off the back of the throat. That's what head tilt chin lift and jaw thrust does. So no traumatic events, no neck or spinal trauma. Um, when we pass out or we go unconscious, our tongue's a muscle. It falls to the back of the throat and it can cause airway blockage. So we open that airway, it pulls the tongue out of the way, and we can deliver that rescue breath. Um, and we'll get into OPAs, MPAs, and all that, but head tilt chin lift, non-traumatic events. Then we've got the jaw thrust maneuver, and this is a terrible picture of it. This is for traumatic events where we might have spinal injury or neck injury. It is a way to manipulate the jaw and lift the tongue without moving the neck or the spine. We're going to practice all this in class. So, let's see. If the patient is adequately breathing and there are no signs of injury to the head, uh, spine, hip, or pelvis, place the patient in the recovery position. Maintain clear airway. Allows vomit to drain from the mouth and roll the patient as a unit. So we have no injuries and the patient is breathing adequately. We put them in the recovery position. So what it means by allows vomit to drain, if they do vomit, instead of aspirating, it will actually pour out of the side of the mouth. Gravity does its thing. There's your recovery position. We've got this, so we roll them and we use our leg and our arm as a tripod to hold us in this position. And then we tuck that upper arm under the head, just kind of as a cushion. We can continue to monitor them. This is really useful if we have multiple patients that we're trying to deal with. Um, One, nobody is going to just fall in this position. So it indicates to other responders that this patient has been seen. Secondly, it, like it said, it maintains that open airway and we can continue our assessment like this. I would still have suction available though. So the combination of lack of oxygen and too much carbon dioxide in the blood is lethal. If a patient is not breathing, ventilations can be given by one or two EMS providers. Use a barrier device of some kind. We don't do the whole mouth to mouth thing. That's just not cool. Kind of gross. Um, in class, when we do this, I'll tell you a couple stories about CPR that I have performed and the things that I've seen in real life, and why I say use a barrier device. For a patient with a stoma, place the bag mask device or pocket mask device directly over that stoma. Artificial ventilation may result in gastric distension, so we need to pay attention to that. Have suction available, unit available in case patient vomits, and they probably will. There's your stoma right there. So we can use a pediatric mask and we can seal it right there over that stoma and ventilate. Sometimes you need to plug the mouth and nose if you're ventilating a stoma so that the air doesn't come out the wrong direction. Single rescuers. Um, so one rescuer CPR, single rescuer gives both chest compressions and artificial ventilations. Ratio of compressions to ventilations is 30 to 2, which we talked about. We're going to do 30 compressions. We're going to give those 2 breaths. Each breath is 1 second or until we get that chest rise and fall. With that being said, if we give a breath and nothing happens, reposition the airway and reopen it. Sometimes that's all it takes. Um, Two rescuer, always preferred to one rescuer. Obviously, it's less tiring. We can swap places as we need to. Facilitates the effective chest compressions. Switch rescuers between CPR is critical to maintain high quality compressions. Recommended to switch positions every 2 minutes. So 100 to 120 a minute, so 200 to 240 compressions. Yeah, you're getting tired. Switch positions. You go run the bag, let the partner do compressions. Um, it's just good practice. Devices and techniques to assist circulation. So active compression devices, CPR, involves compressing the chest and then actively pulling it back up to its natural position. Um, Impedance threshold device limits air entering the lung during recoil phase between chest compressions. So activated compressions, decompress CPR device is what this guy over here is holding. An independent threshold device is what this is. So what he's got here is actually telling him if he's getting 2 inches and then he's getting full recoil is what it's telling him. Mechanical piston driven allows rescuers to conform or to configure the depth and rate of compressions, load distributing band or CPR or vest CPR, a circumference chest compression device composed of constricting band and backboard. Manual chest compressions remain the standard of care. Let me see where this goes. Okay. So the piston driven, if you guys have ever heard someone talk about a Lucas device, this is a device that straps around the patient. There is a piston and a silicone piece that comes down and you position it in the chest and it automatically, you hit start, it automatically goes 2 inches deep. There's videos on YouTube. Uh, as far as I'm concerned, it's the greatest tool in the world if you do a lot of CPR. Um, because once it's on there, you can set it to go 30 and 2. And at 30 compressions, it beeps at you, which tells you to breathe. Or if you have a airway established, you can hit continuous and it will just continue to do CPR for you. So you can go do something else. And someone's sitting there just bagging every 5 to 6 seconds. Um, the band is what this is. Some services do use these. I have personally not got to use one. I've seen them in action, but I didn't use it. And it literally, the whole thing um, compresses the chest instead of the piston driven is focused where the bands kind of compress the entire chest. I don't have a like or dislike because I haven't used one. Infant and child CPR, cardiac arrest in infants and children follows respiratory arrest. There's going to be a respiratory issue that leads to cardiac issue. Airway and breathing are the focus of pediatric BLS. Causes of respiratory problems are injuries, infections, foreign bodies, submersion, electrocution, poisoning, overdoses, or sudden infant death syndrome, SIDS. Determine unresponsiveness, gently tap on the shoulder and speak loudly. Check for breathing and pulse. Um, Assessment occurs simultaneously, should take no longer than 10 seconds. Foreign body obstruction in children is common. Place an unresponsive breathing child in the recovery position. The technique for opening the airway are modified in pediatric patients, which we'll go over in class. Place a wedge under the upper chest and the shoulders when supine. Provide rescue breathing. Not breathing and has a pulse, 1 breath every 2 to 3 seconds. Not breathing and no pulse, 2 breaths every 30 compressions. So it's pretty much the same, right? Interrupted CPR. So CPR is a critical life-saving procedure. If no ALS available at scene, provide transport per local protocols. Consider requesting ALS rendezvous en route to the hospital. Try not to interrupt CPR for more than a few seconds. Chest compression fraction. The total percentage of time during a resuscitation attempt in which chest compressions are being performed should be at least 80%. The higher, the better. So I was going to add something there and my mind just quit on me. Um, we'll talk about positioning in class. Um, Yeah, it'll come to me later. When not to start CPR. So if the scene is not safe, we don't go in, obviously. If the patient has obvious signs of death, so rigor mortis, so stiffening of the body, dependent lividity. So we've got all that blood has pooled to the lower area of the body. So if they're laying on their back, their entire back is going to be purple or black. That's all that blood. Um, let's see. Petrification or decompensation of the body. We don't want to do CPR. Evidence of non-survivable injury. So this is going to be like decapitation. Uh, his head over there, his body's over here. Yeah, we're not bringing this guy back. Um, so these are the reasons not to do CPR. Oh, there we go. That's a good example of dependent lividity. This is the pooling of blood from someone who's been laying there dead for a while. The blood has not cycled. It has seeped through to its lowest point. Gravity has taken care of that. You're not getting this person back. They are probably going to be rigor mortis has set in, and they are stiff as a board anyway. Uh, If the patient or physician have previously agreed on do not resuscitate or a DNR order, when in doubt, begin CPR. So if you remember in chapters, it was like 1 through 4, where all the legal and paperwork and documentation, all that was. We have to have that DNR in our hand. We have to see it. We have to have it, and it has to be signed. If we don't have that, we have to start CPR. Once you begin CPR, continue until the patient starts breathing and has a pulse, which is called ROSC. Um, the patient is transferred to another provider of equal or higher training. You are out of strength, or the physician directs you to discontinue. So know your local protocols. Um, Example, my protocol says I perform CPR at a minimum of 20 minutes with no shock advised. I can then call my medical director and say, this is what we've got, this is what we've done, this is the results. And they will say, yes, you may discontinue CPR. Or if you're all by yourself, you do CPR until you physically cannot go any longer. And at that point, you're about to become a patient yourself. It is okay to stop at that point. Oh, I know what I was going to throw in there earlier. We were talking about rigor mortis. Take into account your environment, which we'll get into this like in environmental emergencies, but if it is a hypothermic patient, it's cold outside or they fell in a frozen lake or something like that, we don't stop until they are warm and dead. Just because they're stiff does not mean that we don't have to do it in certain circumstances. I know that's confusing, but just keep that in mind. If it's freezing outside and they fell in a lake or a pond, we're still going to be doing CPR because they're not dead until they're warm and dead. Airway obstruction may be caused by relaxation of the throat muscle, vomiting, or regurgitation stomach content, blood, damaged tissue, dentures, foreign bodies. In adults, usually occurs during a meal. In children, usually occurs during a meal or at play. Patient with mild airway obstruction is able to exchange air, but with signs of respiratory distress. So the mild obstruction, they are able to cough. Sometimes they are able to speak. They are moving air. It's just uncomfortable. In these cases, we want to tell them to cough. Um, we want to encourage them to cough as hard as they can. I've had one of these where I told the patient, I want you to cough so hard that you throw up. That's what I want you to focus on. A lot of times they are able to move that and get it out. If they are not able to, then it will become a severe obstruction eventually. But Sudden severe obstruction is usually easy to recognize in responsive patients because they are going to do the international choking sign or they are going to be panicked. Their face is going to be either red or blue, depending on how long it's been going on. In unresponsive patients, suspect obstruction is if maneuvers to open the airway and ventilate are ineffective. So they're unconscious. I open it, I try to give a rescue breath, and nothing happens. I readjust my head, I do it again, nothing happens. We've got an airway obstruction. Abdominal thrust maneuver, which used to be called the Heimlich, is recommended in responsive adult and children older than one. We'll go over the Heimlich in class or the abdominal thrust, which looks a lot like that. We go just below the xiphoid process. It's in and up is the process. We're creating pressure within the thoracic cavity to push air out, which should remove that object. Um, Instead of abdominal thrust maneuver, use chest thrust for the following responsive patients. So women in advanced stages of pregnancy, if they are pregnant, we can move up and we do the same thing, but we're on the chest. Or large or obese patients that we can't get our arms around, we just go up on the chest. We're still trying to create pressure inside the chest to push the object out is what we're doing. Um, Once these patients go unresponsive, um, we check for breathing, check for pulse. If the pulse is present and breathing is absent, we attempt ventilations. If it doesn't work, um, like I said, twice, once, nothing, reposition the head twice, or second time, nothing happens. We actually start chest compressions. This is doing the exact same thing. It's creating pressure within the thoracic cavity, and it's going to be forcing air up and out. Um, Hopefully to dislodge that, we open the airway and we look in the mouth to see if we can see it at this point. Um, if we can see it, let's try to get it out of there. If we can get to it safely, we don't want to push it back down. Let's see. Another way to look at this, because I know some people are like, why are we doing chest compressions if they still have a heartbeat? Well, if they're completely blocked off and they can't breathe, they're not going to have a heartbeat for long. So we're going to do whatever we can to dislodge that object. Common problems. If there are signs and symptoms of airway obstruction, do not waste time trying to dislodge the foreign object. Uh, on responsive standing or setting, children perform the Heimlich or abdominal thrust. On unresponsive children older than one, managed in the same manner as an adult. So we do the abdominal thrust until they go unresponsive. Once they go unresponsive, we lower them to the ground and we begin chest compressions. Responsive infants do not use the abdominal thrust, perform back slaps and chest thrust or compressions, which we will go over in class. It's easier to understand when you have a mannequin, but here are a couple photos. The only thing I would change on this one is he needs to be angled downward. This one as well. Let's angle their heads downward so that we have gravity helping us. Between the shoulder blades, we give 5 really good back thrusts. If it doesn't dislodge, it's as simple as we just switch hands. And now I'm going to give chest compressions. And I just keep rotating back thrust, compressions, back thrust. But we want to try to keep that downward angle so that we have gravity helping us. And we do this until they're unresponsive, and then it's just compressions. Um, in unresponsive movements, begin CPR. Chest press. Do not check for a pulse before starting compressions. Open the airway and look in the mouth. Remove the object if seen. Resume chest compressions if the object's if no object is seen. Okay, so special resuscitation circumstances. So opioid overdoses, standard resuscitation measures take priority over Narcan administration, cardiac arrest in pregnancy. Priorities are to provide high quality CPR and relieve pressure off the aorta and the vena cava. Grief support for family members and loved ones. This is one of them that uh, it's hard to deal with. Family members may experience a psychological crisis that turns into a medical crisis. Family members and loved ones will remember this event in detail for the rest of their lives. Keep the family information throughout or informed throughout the resuscitation process. Once again, know your local protocols. Are you going to work this code on scene, try to get someone to remove the family into another room. Are you going to put them in a truck and take off? There's a lot that goes into this. If family is remaining, I have worked full code where the husband stood beside me the whole time, and asked questions the whole time. And the best I could do was do my job, educate him, the simplest form or explanations I could give. Um, when that time comes, though, and you have to step out and call medical control and say, hey, this is what we've done, it's not working, and they say, go ahead and cease CPR, it's going to be one of the hardest things you do. Informing that family, hey, I'm sorry, we've done everything we could. Um, you never know how someone's going to react. My best advice that I can give is do not take it personally. Be empathetic. Collect and clean up your mess that you've made. We have to, I always tell family, everything that we have put in or on them, we have to leave. So please don't remove that. I always ask for their favorite blanket or something and cover that patient up. Law enforcement has to be on the scene before you can just leave. Um, because medical examiner has to come and there's all kinds of stuff. But just remember, this might be that patient's very worst day of their life or that family member's worst day of their life. So we need to be very understanding and compassionate and empathetic towards these people. If they want to scream and cry, we let them do that. We don't ever say, I understand or anything like that. We let them grieve. We can also ask, is there anybody I can call for you? Is there something more I can do? Um, Sometimes, yeah, they want you to make that phone call. So just be prepared for that. After resuscitation has stopped, helpful measures include taking the family to a quiet place, private place, use clear language to speak in a warm, sensitive, and caring manner, exhibit calm, reassuring authority, use the patient's name, use eye contact, and appropriate touch. The eye contact's very hard, tell you straight up. After resuscitation has stopped, um, expect emotions. Be supportive, but do not hover. Ask if a friend or family member can be called. Ensure that children are not ignored. CPR skills can deteriorate over time, so practice often using a mannequin-based training, CPR self-instruction through a video and or computer-based modules with hands-on practice. Once again, this is my personal opinion. If you get your EMT and you go to work for a service, at least once a month, go grab a mannequin and do one cycle of CPR. Get with your partner and run a full code scenario. Break out the training equipment and go through it because I promise you, when these happen, when the real life call drops, nothing ever goes as planned, ever. Um, so practice doing the CPR, practice being the guy who does the bagging, practice hooking up your Lucas. Just every scenario you can think of, practice it once in a while. Get with your partner and work through it. That way, when the real thing happens, it's not as bad of a cluster. Education and training for the public. You are the patient's advocate. You are the voice of that patient. You must do your part to facilitate the training of lay people in critical skills of CPR and AED operations. If you absolutely love EMS, which in the beginning, I promise you will, you'll be obsessed with it. Reach out and see if you can become a CPR instructor. Becoming an instructor has made me 10 times the medic I ever would have been. Um, when you learn to teach to other people, you actually realize how much you didn't know. Um, so yes, get out there, educate people, set up clinics, have classes, educate the community. Okay, brain damage is very likely in a brain that does not receive oxygen for, like I said last time, you can pause these videos, answer the questions, and then we'll move on. I'm going to cycle pretty quick. D, Permanent brain damage is very likely if the brain is without oxygen for 6 minutes or longer. After 10, it is irreversible. Which of the following sequences of events describes AHA chain of survival? So think about that chain. We have to recognize, scene safety. Um, yeah, my mind just quit again. Recognize, scene safety, activate 911, CPR, AED, ALS or EMS, post care, recovery. So C. For CPR to be effective, the patient must be on a firm surface lying in the blank position. Well, we can't do CPR Fowler because that's setting up. Prone, that's laying on your belly. Recovery's on your left, so supine, have to be on your back. The pulse check should take at least 5 seconds, but no more than 10 seconds. If you hit 10 seconds and you're still like, maybe, maybe not, go ahead and start CPR. Quit guessing at that point. D. Artificial ventilation may result in the stomach becoming filled with air, a condition called. It's going to be A, gastric distension, which is going to lead to B, vomitus. They're going to throw up everywhere. So it is A. The blank is just a circumferential chest compression device. I can't say that word. Composed of a constricting band and backboard. So remember that mechanical piston sets right in one spot. It's a piston driven. Load distributing band uh, is probably what I would go with. B. That is the one that covers the whole chest. It's a band that compresses the entire area. Which of the following scenarios would warrant an interruption in CPR procedures? Okay, this one's a little bit trickier. I know which one I want to say, but I'm not going to say it just in case I'm wrong. Okay, C. So when we're transporting that patient, if we're taking that code, that CPR in progress from a home to the ambulance, and there are multiple steps or a few steps, we might have to pause for our safety and patient safety as we move down or across those steps. Once you begin CPR in the field, you must continue until one of the following events occur. Yeah, B. That's the T and the stop. Um, unless someone of our level or a level above us or higher training takes over. Instead of the abdominal thrust maneuver, use blank for women in advanced stages of pregnancy and in patients who are obese. We're going to use A, the chest thrust. And then finally, in infants who have signs and symptoms of airway infection, you should not waste time trying to diagnose a foreign body. You should intervene only if signs of blank develop, such as a weak, ineffective cough, cyanosis stridor, absent air movement, or a decreased level of consciousness. Okay, gonna be D, that um yeah, severe airway obstruction. So guys, that's it, I think. we have made it through CPR. Like I said, I kind of flew through this chapter because we will be doing this in the classroom portion, hands-on, and we'll get a lot more into detail in there. So thanks for sticking it out with me, and I will see you on the next one.